All right, so this is Dr. Moses, and we're going to go into some GI related critical care content here. So, the first thing I want to talk about here is esophageal trauma. And so, when we think about esophageal trauma, the sources of this can be blunt injuries, chemical burns, surgery, whether, they obviously unintentionally could have nicked the esophagus during some type of procedure. It could be from a scope, could be from, depending on the type of surgery. Repeated vomiting, the acidity could cause trauma to the esophagus. When we think blunt injuries, we can think, car accident, but you could also think maybe even like a child from abuse who could have been kicked that could have caused maybe trauma. Maybe not necessarily esophageal, although could happen, but you think anywhere along the GI tract, bowel perf, this could definitely be a source of trauma. When we think esophageal trauma, this is the direct trauma on the esophagus and may have secondary effects on the lungs. And then again, we think about, what is located within the esophagus, the acid, the stomach contents that could be leaking, especially if there's perforation from that esophagus that then could cause problems with, say, your trachea or down into the lungs. Say, repeated vomiting, I could aspirate, which could then again cause effects on my lungs. Excessive force placed on the esophageal mucosa may cause it to perforate, allowing caustic acid secretions to enter the mediastinal cavity. So when we think about like this, these are very, very sick patients. The waste that comes from our bowel or from our stomach content, it's very acidic, especially from our stomach. The perforations then could cause shock, respiratory distress, and sepsis. And, if we think about these people, anybody with like a GI bleed, GI trauma, that kind of thing, they are very sick people. And they can become very, very sick very, very quickly, depending on what type of trauma or perforation we're dealing with. So when we think like a chemical injury, this could be accidental or intentional ingestion of a caustic substance. I will say if this is intentional ingestion, this is a very highly lethal way to intentionally harm oneself. And I think also the problem is if it's ingested even accidentally, the problem is the damage is immediate and can be severe. And there's no takebacks. You can't, realize that you've took that in and try to vomit it up or something like that and prevent the damage. The damage has already occurred, right? If you pour hot water on your arm, well, you get the burn. It's immediate and it can be severe, and you can't take that back. And it's the same thing when you think chemical injury to the esophagus. A strong alkaline substance can cause complete perforation of the esophagus within a minute. So, you think about how immediate and severe that could be. Hemorrhage and aspiration, pneumonia may develop, and then strictures may develop when healing occurs. So, say we do get them to the hospital, they do get the care that they need, we do all the treatment. Well, as that area starts to heal, you can start to have scarring that happens in that esophagus. And, there's not that elasticity that you would have with your normal mucosal lining that comes with your esophagus. So, those strictures then can cause a lot of problems down the road for those individuals. So when we think about our esophageal trauma assessment with these individuals, airway patency is still going to be number one. Like I said, if there's a perforation, that obviously is going to let those secretions can cause trauma, erosion to the trachea. But then also if there's significant edema and swelling to that esophagus, that could also put pressure on the trachea. If I'm aspirating, that can cause problems with my airway. So there's a big concern for airway patency with these individuals, and airway management does become a priority number one concern with these individuals. So when I'm trying to assess their airway patency, do I hear stridor? So that's that real high pitched, it's just that upper airway has closed off. So it's that body's noise of that air trying to get past that enclosed tracheal opening. Do I have gurgling? Do I have retractions? Like your Suprasternal notch retractions can be a very, very telling sign that probably goes along with that stridor that's telling me that I'm using those accessory muscles to really try to get air. Do I have vocal changes, drooling, subcutaneous emphysema, which again, if you remember, that's that like snap crackle, we call it Rice Krispies, that you can kind of feel maybe under the skin. And that's just where that air could have leaked from the airway and has now been trapped underneath in the fat and underneath the skin. So you can feel that under the skin, and it feels almost like Rice Krispies is the best way to describe it, but it's almost like a popping sensation underneath the skin. Do they have changes in their breathing patterns? Do they have dyspnea, tachypnea? Are they wheezing? When we think wheezing, again, that's inflammation of those airways and the bronchioles and down into, deeper into the lung. Any type of inflammation within that lung is where you get the wheezing noises. So that is something we're looking at. And then O2 saturations, of course, how much, if I've got that inflammation, are they getting perfusion of oxygen? Chest pain. I have to rule out cardiac. What is the cause of the chest pain? So I'm looking at location and character. Is it sharp, burning, more pleuritic? Retrosternal pain suggests esophageal involvement, and if it radiates to the back or neck, that can suggest esophageal perforation. And then we think about your exacerbating factors. So is the pain worsened by swallowing, which then could suggest esophageal perforation as well? I think that it's important that you just think about in this situation, a lot of times, especially if there's perforation, if there is any type of trauma to that airway and we are concerned, the incidence and likelihood of intubation is pretty high because we are trying to make sure we protect that airway. And so it is very important that we are keeping that in mind, that intubation with this patient, it's a pretty high reasoning to think that that might occur, and something you should be considering very early on, that this could then worsen, and so trying to protect that airway before it completely closes. Dysphagia, so do they have painful or difficulty swallowing? Can they manage their secretions? Are they choking on things? So if I like to say like esophageal trauma, so maybe there's just some swelling that's going on, but they can still swallow. Maybe they haven't aspirated anything into their lungs. So maybe you can still have some time, and you could do maybe a swallow screen to see like, okay, maybe we've just had some trauma to the esophagus. Maybe there's like some pretty significant erosion from repeated vomiting, but they haven't aspirated. So I would say esophageal trauma is a medical emergency in like lowercase. But then if you've got esophageal perforation, that's a medical emergency in uppercase. Like that is a medical emergency. You're not doing a swallow eval necessarily on somebody with an esophageal perforation, because there's more things going on. You've got leaking acid from that esophagus. I'm really worried about airway. So, I think trauma versus perforation. Trauma is something I'm worried could lead to perforation, but if I've got a perforation, that is a severe medical emergency. Vomiting, I'm assessing for any presence of blood. Is it coffee ground emesis? This obviously is putting them at an aspiration risk. So maybe airway's okay and they haven't aspirated, but if they are vomiting a lot, I am worried about it still as a risk. Like I said, with bleeding, looking color, consistency, amount. So, we're talking esophageal trauma. If I've got black tarry stools, that's a very late sign of esophageal bleeding, because that means that blood has then been swallowed and has made its way all the way down through my digestive tract before it showed any blood. So, black tarry stools would definitely be a late sign, whereas I would be looking more likely could see coffee ground emesis, that kind of thing. If there was a bleed, I'd be looking probably more vomiting and looking at my coffee ground emesis versus the stool in terms of early versus late sign. And then obviously with their assessment, I am monitoring for signs and symptoms of shock, because if I've got that acidic, non-sterile content that is leaking into a sterile cavity, sterile space, this is putting me at risk for getting into my bloodstream, causing sepsis, which could cause septic shock, could cause, a whole different set of issues here. So what does my treatment look like for this? So I'm going to do a bedside endoscopy or imaging if they are stable. I'm going to keep them NPO. And while they are NPO, these individuals, while they heal, they're going to be NPO for weeks, right? So we're doing TPN and lipids to provide nutrition while they are NPO. We can do an NG to suction, which would allow the esophagus to rest, but this is typically for more than a week. So they're sick people and are going to require some long-term treatment to allow the esophagus to heal. We would do broad spectrum antibiotics to prevent sepsis, high dose corticosteroids to reduce inflammation and to prevent strictures. So like I said, especially like with your airway and with the wheezing and the stridor, these high dose corticosteroids are very important to try to reduce any inflammation that could be going on in the airway, because we want to keep that airway patent. And if I have, say, swelling, even with just trauma, not a perf, I would want to reduce swelling of the esophagus, because swelling of the esophagus could still put pressure on my trachea, which could then restrict my airway. So those corticosteroids are very important to reduce the inflammation, help prevent strictures. Pain management, they're in a lot of pain. So appropriate pain management. Lidocaine could be used as a viscous solution inside the mouth for caustic injuries. May need surgery to remove damaged tissue, and they may need a G-tube while healing and or for life, depending on how much damage has been done to the esophagus. So moving from just like esophageal trauma or esophageal perforation would be like an acute GI bleed. This is a medical emergency, okay? This could be an upper or a lower bleed. We are looking for bright red or melena stool coloring, dependent on the location in the bowel would then dictate, the coloring of that stool. We want to look at their hemoglobin, hematocrit, and electrolytes. Obviously, if I've got an acute GI bleed, I would expect my hemoglobin and hematocrit to drop, right? I am losing blood. It's as simple as that. That hemoglobin and hematocrit could be, really dropping and dropping really fast. Okay. If I'm losing blood, I'm also losing fluids with that. I'm losing everything inside my vascular space. I'm also going to have electrolyte imbalances. All right. Monitor, obviously, for signs and symptoms of shock. They can go into shock very quickly. Hypovolemic shock by blood loss. One thing we can do as a nurse, if somebody comes in with this acute GI bleed, if I'm losing a ton of blood, I'm also losing my pressure. So I'm going to be hypovolemic. I'm going to be hypotensive. Something I can do as a protective measure is put them in Trendelenburg, try to help keep perfusion to the brain the best I can. And then I'm obviously going to need orders for blood products and isotonic fluids. Now, if I've got an acute bleed, isotonic fluids, they're great. They're going to help fill the vascular space, but they're not filling it with blood, which is what I need. So they're better than nothing, but they're not going to fix my problem. So, these individuals could get 8 to 10 units of blood for an acute GI bleed. And this isn't like, you're starting it slow for the first, 15 minutes and then you infuse over 4 hours. You can see nurses, they're just squeezing these bags of blood in because they're losing it so quickly if it's a big enough bleed. They need 2 large bore IV catheters that can handle the pressure of, significant and intense blood therapy in those situations. I think, something that's kind of difficult to manage with an acute GI bleed if somebody comes in and they have a very significant bleed like this is if there is some type of hemorrhage, blunt force trauma, or something like that that has happened and caused that bowel to be bleeding. We can't see where it is because it's internal. So it's not like a gunshot wound where you can see visibly where they are bleeding and hold pressure. You can't hold pressure for this because you don't know where the bleed is occurring. So it's really hard to manage this individual because you can't You can't see where it's coming from, so you can't hold pressure. And so you got to get them stable enough to be able to get them to the OR to get in there and figure out where the bleed is occurring to get it to stop. But that can be very difficult if they're bleeding so fast that you can't replenish it as fast as they're losing it. Other things that are very important to take into consideration with acute GI bleed, their medication history. Are they on blood thinners? That's obviously a big key component that you're looking at with so many individuals. If they are on a blood thinner, thinking about how difficult then it would be even to manage that bleed and to try to get it to stop. So like I said, an NG tube is something that we could potentially place for these individuals. And that was, when we was talking esophageal trauma, but also with an acute GI bleed. And we can do this again. This is going to be a good assessment tool for us. If you drop an NG tube, first things first, you're going to be able to see how much blood do you pull out of the stomach. Okay. This is going to kind of give you a little bit of an indication as well. Where are you dealing with a bleed? If you pull out significant bright red blood, that could be indicative of maybe location. Is also going to give me an idea of rate of bleeding. It's going to help prevent gastric dilation and help decompress the system, so it causes kind of that gut rest. It slows things down. That would maybe then help the body start to heal itself. You can clamp it, and then after 72 hours you can check the residual. So did you have a lot out initially, but then it kind of slowed down after it got the initial out? So it can kind of give you an idea of maybe the rate in which somebody might be losing blood. Interventional radiology or endoscopic therapy may be needed for source control, figuring out where it's coming from. And the sources may be treated with like heat, lasers, they can clip, or they can use chemical injections to like cauterize or cause that area to stop bleeding. So an intestinal obstruction is going to be, it can be either partial or complete, and it can be mechanical or non-mechanical. And so a mechanical is like the bowel is physically blocked by problems outside of the intestines, such as adhesions. You can see this like with PCOS, somebody, maybe can get adhesions that can cause bowel blockage. In the bowel wall itself, such as Crohn's disease, you can get those adhesions, or in the intestinal lumen, like just a tumor inside the bowel that could cause a mechanical physical block. Non-mechanical, there's no physical obstruction. Instead, peristalsis is decreased or absent due to neuromuscular disturbances. So this is where you think about your primary cause of a non-mechanical is your paralytic ileus, okay? So when we think about the patho that comes into play here, we have abdominal distension that occurs due to the inability for the intestines to absorb content and move waste through. So depending on, mechanical or non-mechanical, partial or complete, I'm still having the inability to get that waste beyond a certain point inside that bowel. And so once I have that blockage, I'm going to have distension that's going to happen in the belly because it's just starting to build up in there, right? Due to the delay and due to the inability to move things, our body's defense mechanism, is to try to increase peristalsis to move things along, move things quicker through the bowel. If you've got constipation, well, you can take a stimulant laxative, which will increase your peristalsis to help you have a bowel movement. And so your body's natural defense mechanism here is to try to increase peristalsis. But this is one of those situations where our defense mechanism that our body has naturally built inside does more harm than good because it's not moving this blockage forward. So it can create additional secretions, which can then worsen the distension inside that bowel. So this distension then increases the intraluminal pressure, which impairs venous and lymphatic drainage, which then causes the bowel wall to become edematous and thickened. As then it becomes swollen and thickened, and this is then going to cause a decrease in your capillary perfusion, which can then, if I'm not getting blood to the bowel, I'm going to lead to ischemia. I can lead to mucosal injury and an increased permeability. So it just starts leaking stuff out because it just doesn't have the ability to drain like it did. So then I have that increased permeability. So then I can have the plasma leak into the peritoneal cavity and fluid trapped inside the intestinal lumen, decreasing the absorption of fluid into the vascular space. So if it's not going into my vascular space and it's trapped, I'm going to then start to see changes in my cardiovascular. I'm going to see hypotension. I'm going to start seeing some changes in my electrolytes because I'm not getting the fluid that's then trapped into the vascular space like it's supposed to go. You know, with a partial, it might not get as bad as quickly as a complete. You get a complete blockage, you're going to see these people get sick and get sick fast. All right, so like I said, the reduced circulatory volume because of the decreased absorption of fluid into the vascular space is now going to cause hypovolemia, which can be anywhere from mild to extreme to lead to shock. So that it's kind of hard to say what that's going to be. It depends on location. It's going to depend on the severity. So it can range. I can see fluid and electrolyte imbalance that's present. You know, if I've been vomiting a lot, you know, we know that obviously causes an electrolyte imbalance. Third spacing that occurs because that fluid's not going where it needs to go. And third spacing is just real, that truly just means it's fluid going somewhere it's not supposed to go. But if that fluid is not going either into a cell or into the vessel, I'm not getting any of the electrolytes or any of the nutrients that I need from that fluid. And if that fluid that has my potassium and has my sodium in it is hanging out in a third space and not going into a cell or into the vessel, then I'm going to see electrolyte imbalances. So I would see hypo and kalemia and hyponatremia with these individuals. My acid-base balance may be affected. So early stages, especially with a high obstruction, I can see metabolic alkalosis, and this is just due to the loss of gastric acid from persistent vomiting. This can be very common in your pyloric or upper small bowel obstructions. Now, I can see metabolic acidosis like in the late stages, but especially with distal obstructions and bowel ischemia. So if I've got prolonged dehydration and hypoperfusion can lead to lactic acidosis from anaerobic metabolism. Okay, so the cells are not getting, you know, what they need, and so that causes that lactic acid to be created. The loss of bicarbonate due to sequestration in the bowel, particularly in lower intestinal obstructions. And if bowel necrosis or perforations occur, septic shock can develop, worsening metabolic acidosis. So this statement is kind of a reiteration of the previous patho, but I think it's important, you know, as it accumulates in the obstructed bowel and the impaired venous and lymphatic drainage wall with the edema, I get the weakened barrier allowing bacteria and endotoxins to enter the bloodstream. So if this obstruction persists and I get this increased pressure and I get a reduced in arterial blood flow, it can cause ischemia to the tissue and tissue necrosis, which then if I've got all these endotoxins entering into my bloodstream, that can cause sepsis. And if that bacteria gets into the peritoneal cavity, I can see peritonitis with these individuals. So an intestinal obstruction can occur anywhere but the ileum is the most common site. And that's just because the ileum, it's a very narrow lumen and it's highly active in peristalsis, making it much more susceptible to blockages. A postoperative ileus is common. So this is, you know, a paralytic ileus or a postoperative ileus, meaning it's just not moving, is common after handling the intestines during abdominal surgery, and it may lose function for several days or hours. And so it's so important that you are doing a good post-op bowel assessment. You know, anybody who's had especially abdominal surgery, your body's mechanism to try to protect itself is if that bowel, it almost makes you think like a turtle. You know, it's a defense mechanism. If somebody comes up and picks it up, what does it do? It goes into its shell. And you have to set it down and you have to like go away and let it feel safe before it will peek its little head out again and then go walk away. So your bowel kind of does the same thing. It kind of just shuts down if it's been manipulated. And then it takes a little bit before it like starts to wake back up and, you know, scope things out before it feels like it's safe to go anywhere again. So it's really important that you're assessing those bowel sounds to make sure that their bowel is waking up from that surgery. All right. And another thing is if they actually had their bowel cut on, well, you're going to be cutting nerve endings inside that bowel. So, of course, it's going to take a little bit for those nerves to start to regenerate and to start to wake back up. So, you got to think about it that way too. All right. So, our assessment, we're looking at our emesis color. Is it yellow, green, bloody? We can get a lot from the color of the emesis. Do we have abdominal distension? Is it mild? Is it severe? Is it present at all? What does that look like? Bowel sounds. So if it's above the obstruction, an early sign that I can see is if I have caught very early, even with it complete, I could still have high-pitched bowel sounds as an early sign, because that is just the peristalsis. That is the noises my bowel is making as it increases the peristalsis. So I can have like high-pitched tinkling bowel sounds found above the blockage, and then I might have absent or normoactive or whatever below the blockage. Could sometimes give you an indication of where the blockage might be, but a late sign would be then just no bowel sounds whatsoever. My pain assessment is important. Severe pain that then stops or suddenly goes from like sharp shooting to like just dull and tenderness could maybe indicate a perforation. Pain from an infarction will be severe and constant. So we have to think about, in most instances, we consider pain psychosocial. But in the instances of ischemia to an organ or some type of function, some tissue losing oxygen, that pain from an infarct is ischemia. And that is those cells screaming out for help because they're not getting oxygen and they are dying. Okay, so the pain from an infarct would be severe and constant. That is not a psychosocial pain. That is a physical pain telling you there is cell death going on and we need to do something about it. Elimination pattern. So, are they passing gas at all? What is the time, character, and consistency of their last bowel movement? Hiccups are a common finding with some of these individuals. An uncomplicated obstruction would be like a fever less than 100. But if it's over that, then we're starting to worry more about tissue necrosis, peritonitis, some type of sign of sepsis, infection, something going on once that fever starts to get over 100. Mid-abdominal pain is often present, could be sporadic, or if it's strangulation is present, it could be persistent. We could have guarding, that kind of thing. More so with upper versus lower, but we could see vomiting present with an intestinal obstruction. And complete obstructions will have no passage of stool, and a partial will have diarrhea. And the best way to think about that is, if there's a complete obstruction, I've put up a wall and there's no going past it. But with a partial, something can still get around it. So you think about your bowel being circular and say there is an obstruction that is still allowing something around it. You think about a river with a giant rock in it. Well, if you put up a dam, the water's not going past it. But if you just had maybe a grate or you had something along those lines, things can still get past it, but maybe bigger things can't. So maybe a grate would be a good way to think about it, like a drain that goes into a sewage system. Like it might keep out some of the bigger things, but it lets the smaller things through. And it's kind of the same thing that happens with a partial blockage. My body's still increasing peristalsis, which will then make the stool more liquid, okay? And because it's doing that, the liquid is then able to seep past the blockage, but nothing solid is getting past it because it's too big. So then these individuals, they might be confused because they're thinking, well, I have an obstruction. Why am I having bowel movements? I shouldn't be having bowel movements. But with the partial, they very well might have bowel movements, but it's probably going to be more in the terms of diarrhea than an actual formed stool. So this is just a nice little table that helps kind of maybe differentiate between a small versus large bowel obstruction. And so when we think about like common causes, for a small bowel obstruction, your most common are adhesions, but you can have hernias, tumors, intussusception, volvus or strictures, and then most common causes of a large bowel obstruction are tumors, but then diverticular disease is another common cause, fecal impactions, and strictures. Locations, for a small bowel, you're talking your duodenum, your jejunum, and your ileum being the most common. And then for your large bowel, you're talking cecum, colon, rectum. Symptoms, a small bowel can be rapid onset. You think about what you might see: bilious vomiting, marked dehydration, high-pitched bowel sounds. Whereas with a large bowel obstruction, it's going to be more of a gradual onset because things have went further down into the GI system, but you can have your lower abdominal pain, distension, constipation, normal and or hypoactive bowel sounds. With your small bowel obstruction, early signs with your bowel sounds are those high-pitched, tinkling, hyperactive, and then late is absent if the ischemia occurs. And then with a large bowel, initially you're still normal active or even hypoactive, but it may become absent if a perf or necrosis occurs. Vomiting is rare with large, but much more common in a small bowel obstruction. And you can have bilious or even feculent. So that's, people are vomiting up stool in some small bowel obstructions. That's something, if you've ever had to experience, you never want to experience seeing again. Distension, because you don't have as much buildup, and the small bowel isn't quite as capable of expanding like the large colon. So you have much more distension with a large bowel versus a small bowel. Risk of ischemia and perf, there's a higher risk from a small bowel because it's due to the thinner wall and greater compromise of blood flow. But then large bowel, it's lower risk initially, but can lead to toxic megacolon in severe cases. You've got your radiographic findings of a dilated small bowel loops and air levels, stepladder patterns on x-rays, and then you get a dilated colon is your most common there with a large bowel. And then your different management for each. So when we talk about our labs, your white count should be normal unless you're starting to see signs of necrosis or you're starting to see signs of infection. Your hemoglobin hematocrit with an obstruction, this is typically elevated because of dehydration. If I'm vomiting a lot, I get that hemo concentration. So I'm losing a lot of the fluids, but I'm not losing maybe the blood. So then that would cause an increase in my hemoglobin hematocrit and an elevation of my BUN, which would be indicative of dehydration. And then my sodium and potassium would be decreased because I'm not absorbing those electrolytes within my body. So imaging, they might start with just an abdominal x-ray. They can look for dilated bowel loops with air, which could be a classic sign of an obstruction. A string of pearls is something that they will call a sign, which is seen in your small bowel obstruction. And then absence of gas in the rectum suggests a complete obstruction. Your preferred imaging with an individual, though, with this obstruction would be a CT of the abdomen, pelvis with IV contrast, because it's going to help identify transition points in the severity. It's going to help detect ischemia, strangulation, and or perforation. And it can differentiate mechanical obstructions versus an ileus. If we are doing a CT of the abdomen with IV contrast, we obviously have to be thinking about what do we take into consideration with IV contrast? Their allergies to either iodine, shellfish. Have they had any type of contrast before? Holding, metformin or something along those lines, medications that do not play well with contrast. So those are things we need to keep in mind with contrast with these individuals. And then ultrasound, you see this more so in pediatrics or with suspected intussusception, which you talk about that in pediatrics. I won't necessarily go into that, but they do sometimes use ultrasound for intussusception, volvus, or hernias. So what does our treatment look like for these GI symptoms or for these GI obstructions? So we're obviously making them NPO. Prevents worsening or distension. If I've got an obstruction, I don't need to be putting more in because that's just more to back up. Okay. It's going to reduce my risk of aspiration because, again, if it's a small bowel obstruction and I'm vomiting a lot, then that puts me at risk for aspiration. So just nothing by mouth. We're putting them on, a gut rest, letting their bowel try to heal. Partials can sometimes heal themselves if you give them time. IV fluid resuscitation to correct dehydration and electrolyte imbalances, potassium replacement. So if they're hypokalemic, we know hypokalemia is a huge risk factor with cardiac dysrhythmias. So I got to make sure that I'm giving them the appropriate potassium replacement if they do have hypokalemia. NG tube decompression. So this helps relieve distension and vomiting by suctioning gastric contents. So these people with partial bowel obstructions or suspected bowel obstructions, first thing you basically see for them is they get gut rest and they get that NG tube, and it's used for complete severe vomiting or significant distension and can help resolve some partial obstructions non-surgically. So if they do the imaging, they think it's a partial, they're going to try to not have to treat it surgically. So they'll start with gut rest, see how those individuals tolerate that, if their body starts to naturally, work through that obstruction, or, then if they do need to go surgically, they will. Pain management, we want to avoid opioids if at all possible, because we know with opioids, they slow bowel motility. And so if they cause constipation, and that's a huge issue with opioids to begin with, well, the last thing I need to do is put them at a greater risk for an obstruction due to constipation and decreased bowel motility. So I really need to try to consider like IV acetaminophen or NSAIDs. Toradol is a great one. Ways in which I can try to manage the pain without using opioids. But if I need opioids, then using low-dose fentanyl or Dilaudid can be used. I just need to be using it cautiously. And then monitoring for signs of worsening ischemia or perforation. And I think that it's important that when you say that, you've got to have a good idea what your patient's baseline assessment looks like. All right, they're already sick, they've already got an obstruction, whether it's partial or complete, or if it's partial, does it become complete? So I need to be able to start recognizing changes from their baseline. Are we treating them with IV medication, pain medication, but all of a sudden now their pain has become a 10 out of 10 that's not treated with my pain medication that was working earlier? Do I start to see an increase in heart rate? Do I start to see signs of fever? So do I start to see signs of infection, hypotension, lactic acidosis, which then could be from necrosis, which all of those are then telling me I've now went from maybe a partial blockage or complete or whatever to worsening ischemia, or now I've perforated. So treatment-wise, many partials will resolve with conservative management alone. So, you do the gut rest, electrolyte replacements, giving them plenty of fluids, just try to let it naturally resolve itself. A complete small bowel obstruction or worsening partial obstruction then could require surgical interventions such as a laparotomy or laparoscopy. And indications for immediate surgery would be strangulation, which causes ischemia and necrosis, perforation, or failure to improve with conservative management. A large bowel obstruction, most are mechanical large bowel obstructions that require surgery. If it's due to colonic volvus or endoscopic decompression, with sigmoidoscopy may be attempted first, but then if we have like malignant structures or tumors, that kind of thing that needs stenting or just bowel resection, then we start going down into the route of needing ostomies and that kind of thing. And we'll talk more about like malignant structures, colon cancer, and ostomies in a different presentation. And then with the paralytic ileus, we're going to do supportive care, fluids, electrolyte correction, MPO if needed. This is why it's so important that post-op they want people up, moving around, because ambulation is one of the best things you can do to try to wake up that bowel. Limit, obviously, opioid use, like I said. Consider bowel stimulating medications, Regulin, erythromycin as needed. And then if they have severe distension from the paralytic ileus, then you might see an NG tube placed. And I think that covers everything in terms of like small bowel obstruction, large bowel obstruction, acute GI bleed, and esophageal trauma.